Good morning and welcome to today's presentation. Our presenter today is Dr. Karabo Mahuma. Dr. Mahuma is a dedicated and passionate chemical pathologist, currently serving as part of the dynamic team at PathCare. Her journey in medicine began at the University of Pretoria, where she obtained her MBChB degree in 2014. Following this, she completed her internship and community service in Limpopo, an experience that nurtured her understanding and deep respect for the complexities and resource challenges of healthcare delivery in rural settings. As a medical officer, her interest in laboratory diagnostics later propelled her to obtain her specialist qualifications from the Colleges of Medicine of South Africa in 2023, followed by completion of her Mmed from the University of Pretoria in 2024. She remains enthusiastic about bridging the gap between clinicians and laboratory personnel in pursuit of quality healthcare for all patients. Thank you so much.
Okay. Good morning, everyone. Thank you for the introduction. The title of our talk today is Wrestling from Within, and from the title, it just alludes that we'll just be going an overview over hemochromatosis. So just the contents of my talk, just a brief introduction, an overview of the prevalence of disease, a view of pathophysiology, diagnostic biochemical markers that we have at our disposal, clinical presentation and complications, and of course, types of hemochromatosis, and just a brief overview of the treatment options that we have. So hemochromatosis is defined as a disorder of iron metabolism, and this is characterized by excessive iron absorption. And this buildup of iron is resulting in an accumulation of deposition in various tissues. And this gives rise to the different symptoms that patients can present with due to organ dysfunction. So not just overload, but the name coming or alluding to the fact that there is discoloration to an extent of, or a change in color of tissues due to this accumulation of iron pigments. So hereditary hemochromatosis or primary hemochromatosis, and this term being restricted to causes that are due to mutations in the genes that are responsible for iron homeostasis. So while they may be, while many of the secondary causes of hemochromatosis may be due to genetic defects, the term hereditary hemochromatosis is restricted to that primary iron overload disorder. So just looking at a brief history of the hemochromatosis and how far we've come, the initial description of a case report first recognized in the 1880s, where Armand Trousseau identified a case report where he described this bronze diabetes and pigmented cirrhosis. But later on, colleague Fern Reckelhausen was credited with the first use of the term of hemochromatosis. He identified a syndrome characterized by diabetes, cirrhosis of the liver, and the bronze-like discoloration of the skin, which he termed bronze diabetes. And we noted that Sheldon in 1935 was able to demonstrate, or he realized that there may be a familial pattern of hemochromatosis and suggested that this disease could perhaps be due to an inborn error of metabolism. And then with later in the 1996 identification of a major mutation responsible for hemochromatosis was discovered, and this is of importance because of the common occurrence of the specific mutation. And as the years progressed, there was recognition or increased research that demonstrated the key role that hepcidin played in the pathogenesis of hemochromatosis. And to date, we are seeing an expansion of genetic testing that has allowed for us to be able to diagnose patients quite efficiently and more optimally before we see adverse or target organ damage. So the prevalence, so this is a disease, is a quite common genetic disorder in Caucasians, especially in the United States and in Northern Europe. Despite the high prevalence of this gene or the prevalence of these gene mutations, the condition seems to demonstrate variable clinical expression and low penetrance. So basically the mutation causes clinically relevant phenotypes only in some a minority of cases. So it is demonstrated that approximately 1 in 6 Caucasian population in South Africa, and this was a study done by Ferda et al. In 1996, that where genetic studies performed in South Africa, also by De Villiers in 1999, demonstrated or identified genetic defects in more than 80% of patients with hemochromatosis. They showed 1 out of 6 Caucasians were carriers of that common iron-related mutation in the HFE gene. And this translates to almost 1 in 100 to 115 South Africans of European descent, which may be homozygous for this founder mutation. But as we said, the clinical presentation varies, and therefore a lot of people, although they may be carriers or even present as homozygous for this mutation, the penetrance of this disease may not vary in clinical presentation. And also because of the varying in the presentation with non-specific symptoms, these patients are sometimes overlooked or this diagnosis is not initially thought of. There's also a prevalence of hemochromatosis in males, men being more affected 2 to 3 times more than women. And usually this becomes apparent in men in the 5th decade, with women often presenting quite late in the 6th decade, and this being due to the iron loss that these women have through menstruation and childbearing. Okay. So at the key of more specifically your hereditary hemochromatosis, the pathophysiology. So usually there's a defective response of hepcidin, which we will look into now, but hepcidin response in relation to iron stores, which results in excessive iron absorption in the duodenum. So hepcidin controls iron metabolism. It does this by binding to ferroportin, which is a major cellular iron exporter, and this allows for its internalization and degradation, and this prevents or reduces iron efflux out of the cell in cells such as the hepatocytes and macrophages. So this hepcidin-mediated loss of ferroportin is important because it leads to a decrease in intestinal absorption of inorganic iron. So one can imagine that a defect in this would result in accumulation of iron in various organs. So hepcidin is encoded by the HAMP gene, which stands for hepcidin antimicrobial peptide. What this does is that as we said, its expression is induced by excess iron, so it's in a body's attempt to downregulate iron absorption by that degradation that we spoke about. Of note is that it is also an acute phase protein, and it is also has antimicrobial activities. It works directly by disrupting bacterial cell membranes, and this also through macrophages by restricting access of iron by organisms and thus preventing their growth. in acute or inflammatory states, interleukin-6 or cytokine interleukin-1 stimulate hepcidin production, and this reduces your iron release. So it's regulated by various factors that the same factors that would regulate intestinal iron absorption, the status of iron stores, any erythropoietic activity, or as we said, in inflammation states would affect this expression. So this is just a diagram to illustrate what we were just talking about. So from the diagram, okay, so you have iron uptake where iron, that dipheric iron bound to your transferrin, and this detection of the iron status response with hepcidin binding to ferroportin, and thus causing its degradation and therefore regulating systemic iron homeostasis in the duodenal enterocytes. And various sources, whether heme or non-heme, they are reduced to form so that they can be absorbed through your divalent metal transporter. And all of these are released into circulation pending the integrity of that ferroportin. Also, additionally, the consumption of damaged erythrocytes, especially in your splenic macrophages, leads to the release of iron with the macrophage followed by the efflux by ferroportin. So you can see the expression of this in various parts of the body. So this diagram is just to illustrate the effect of hepcidin. We also said it in the previous slide, but there are mutations in either the hepcidin gene itself, in genes affecting, or also in genes affecting activators of hepcidin expression. So we will also look at these when we go through the types of hemochromatosis where different genes affecting the activators of hepcidin expression are affected, or in other cases also the ferroportin, where there are mutations demonstrated in the ferroportin itself. So this is just to explain what the interaction of your HFE protein with relation to transferrin receptors. So the hemochromatosis and the two transferrin receptors, namely transferrin 1 and 2. So basically, when iron stores are low, the concentration of dipheric transferrin is low, and in the absence of dipheric transferrin, the transferrin receptor 1 binds to your HFE on the plasma membrane of the hepatocytes, and then the transferrin receptor 1 also outcompetes transferrin receptor 2 for dipheric transferrin. So the combined effect of this complex that is formed and the presence of apotransferrin receptor 2, which meaning without any attached iron, would decrease the signal to produce hepcidin when the hepatocyte iron stores are low. And the opposite would occur when iron stores are actually high. When iron stores are high, the increasing level of dipheric transferrin results in dipheric transferrin displacing HFE from transferrin receptor 1, and the more dipheric transferrin would be available to bind to a transferrin 2, and the combined effect of this would create an intracellular signal resulting in increase in hepcidin and therefore decreased absorption. So taking a look at the types of hemochromatosis, the classical type or type 1, HFE related, as it's also termed, as an autosomal recessive disorder. Both HFE and beta-2 microglobulin are needed for normal iron regulation. So there is a binding site for your beta-2 microglobulin. So in the most common mutations, there's disruption of a disulfide bond in the HFE protein, and this impairs its ability to bind to beta-2 microglobulin. So as a consequence, HFE will be unable to reach the cell surface, and therefore it accumulates intracellularly. And this causes impaired signaling, leading to the reduced hepcidin expression at a transcriptional level. There's decrease in hepcidin levels and excessive systemic iron accumulation. And this condition generally presents in patients over 40 years of age. So although the molecular mechanism is sometimes poorly understood, it has been proposed that the HFE plays a regulatory role in sensing your transferrin concentrations and playing a role in protein interactions between the HFE, as we illustrated in the previous slide, the interactions with transferrin receptor 1 and 2. That high concentrations of iron-bound transferrin dissociate HFE from the receptor 1, and this strengthens the interaction of HFE with transferrin receptor 2. There are also other common or less common rather mutations that arise, and also that we do test when we do genetic genotyping for HFE, and these are illustrated here. So from the common mutation where there is a substitution at a transcriptional level that results in substitution of amino acid tyrosine for cysteine at position 282, and that gives rise to the name, and then subsequently also less common mutations. So these mutations increase the expression of divalent metal transporters that we saw in the previous diagram, and this allows for inappropriate increase in intestinal iron absorption. But of note is just that the common one that we do find is that the first mutation, as we see from the slide. I think I did elaborate on just before. I think it's just to re-emphasize what we just said. So they are the risk of significant iron overload may not be apparent in your carriers for the less common genetic mutations, whereas there is a significant iron loading where you have a common heterozygous compound heterozygote where you have your common mutation, the C282Y with the H63D. And the compound heterozygote is said to have increased, but also estimated to be nearly 200-fold lower than patients who are homozygous for that common mutation. So the relative contribution of the less common mutations to just the overall incidence appears to be quite minimal, but although this association is not well defined, it appears that compound heterozygous, whether you have it with either of the two less common mutations, is said to have an increased risk for patients to phenotypically present with clinical hemochromatosis. So with type 2, also an autosomal recessive disorder, historically this disease was also referred to as juvenile hemochromatosis based on the age that these patients typically present. So you would expect younger population, so less than 30 years of age, presenting with symptoms, and the mutations are in two different genes. So then you have your type 1 where there is a defect in your hemojuvelin, and then hemojuvelin expressed in your hepatocytes and is involved in regulating the hepcidin pathway. And normally, a muscle normally sheds this hemojuvelin in low iron states, which interacts with the receptor on hepatocytes and downregulates hepcidin production. And in type 2B, where it's the actual defect or responsible in HAMP, which is responsible for the hepcidin gene itself, and therefore there is dysregulation of expression of hepcidin itself. And these patients would normally present with cardiomyopathy and hypogonadism as the prevailing symptoms that they would normally present and complain with. Type 3 hemochromatosis, also an autosomal recessive disorder, typically in ages 30 to 40 years old, and this is due to mutations in the transferrin receptor gene, and mutations in this gene that encodes, we saw in the previous slides, the importance of that transferrin receptor 2 in relation to its interaction with HFE. So the function of this transferrin receptor 2 in the liver is to sense iron levels and act as a regulator of hepcidin function. So when this receptor binds to dipheric transferrin, and this results in increase in hepcidin, and therefore binding of that increases in hepcidin signal, and regulation, therefore it's upregulated, and this results in decreased absorption in consequence to the high levels that it senses. So clinically, these patients will present classically just like classic type 1. And then type 4, an autosomal dominant disease, and this has a variable age of onset, can vary from quite young to even as late as 80 years of age. This is due to either a gain or loss of function mutation in ferroportin. So a gain of function mutation in ferroportin would illustrate as a resistance to hepcidin, and thus preventing ferroportin internalization and degradation, resulting in iron overload. By contrast, patients that have a loss of function mutation in ferroportin have a diminished ability for reporting for iron export, which is characterized by iron accumulation in macrophages and in the spleen and in the liver. And this is the only type where they would have high hepcidin levels that are demonstrated, but the resulting defect that there's excessive ferroportin, either its resistance or inability to respond, which results in excessive intestinal iron absorption. So this is just a diagram to illustrate what we just said and the differences in the different types, and also which genetic mutations one would look for. Also to note that there are many other causes of secondary hemochromatosis or non-genetic or not primary. So patients that are receiving a lot of iron supplementation or multiple blood transfusions, patients who have chronic liver dysfunction. So basically with chronic liver disease, there is injury or inflammation in the liver, causes ferritin to leak out into the bloodstream. And also in patients with dysmetabolic iron overload syndromes, where there's a correspondence of increase in liver and body stores associated with various components of metabolic syndrome in the absence of any other cause of iron excess. So in these patients, there would probably be increased BMI, visceral fat, hypertension, dyslipidemia, abnormal glucose metabolism, and steatohepatitis. In patients who have hematological disorders where they may be ineffective erythropoiesis, so there's this increase of erythropoietic drive that leads to suppression of hepcidin, and that in that case has increased absorption from the gut in an attempt to address this. Chronic inflammatory conditions, we mentioned a little bit about our how the effect of inflammatory cytokines, especially interleukin-6, and how this would affect hepcidin. So in acute infections or chronic inflammatory processes, autoimmune diseases, the liver increases ferritin synthesis during inflammation, independent of iron status, and often you would find that the ferritin is quite high, but the iron is sequestrated in macrophages, leading to almost a functional iron deficiency or a picture of iron transport block, if one can say. Malignancies also can induce chronic inflammation with the stimulation of your cytokine release that also boosts your ferritin. Tumors, some tumors may cause direct damage or hemophagocytic activity. And so certain cancers such as leukemias and lymphomas may also involve the reticular endothelial system where ferritin is stored, and this would result in release or excess release of this iron. Ethanol, a huge problem. So ethanol with regards to liver injury, but also directly also suppressing hepcidin synthesis, along with sometimes being found with dysmetabolic iron overload. So clinical presentation of hemochromatosis, it is, as we saw earlier, that there are quite rare forms of hemochromatosis or primary hemochromatosis where in young, so it's rarely in young individuals, and most commonly after age of 40, and with women presenting well after menopause due to that slower iron accumulation in premenopausal years, so they're almost delayed in their presentation. But the majority of hemochromatosis patients are usually investigated as a result of other non-specific symptoms where they're just chronically fatigued or have joint problems or liver disease, most of them having liver disease, or even in some cases where there is an affected family member that elicits for us to investigate further. So at the heart of diagnosing or screening or having even a suspicion of iron overload disorders, we would order iron studies. So just a brief covering of iron. So we know that iron has a diurnal variation, so it's higher in the morning. And just of note, preanalytically, hemolysis can falsely increase levels. So in an optimal sample would be a sample that has no hemolysis. Iron can be increased by various things like oral contraceptive, hepatitis, anemias, or even iron therapy patients, obviously, who are taking supplementation, but decreased in infection or inflammation, or carcinomas or iron deficiency, or even hypothyroidism. It's said that this would decrease iron levels because it reduces erythropoiesis that alters how the body uses iron and binding. Yes. And then transferrin, optimally a fasted sample. We do know that it is a negative acute phase reactant, so it would be quite decreased in chronic disease, inflammation, liver disease, malnutrition and nephrotic syndrome, and increased in iron deficiency pregnancy or contraceptives. And this really complicates the interpretation of iron studies in inflammatory states. And when in doubt, we could order soluble transferrin receptor that could give us an indication of whether there may be underlying iron deficiency, for example, or anemia or chronic disease based on whether it's increased or it's normal. And ferritin being the major storage protein correlating well to iron studies, and this is just of note that it's obviously in patients that are not in an inflammatory state, because it is a positive acute phase reactant, and those are some of the conditions that we would find increased levels. So from this list, you can see that although all these secondary causes of hemochromatosis are probably so much more common than hereditary chromatosis, but if one is excluded or has less suspicion of it, it's always good to think of the hereditary type, because we are at a point where it is easy to test for these genetically, which I will go into now, but it's something at the back of our minds to think of once we've excluded all these other secondary causes. So investigations, as we said, so screening, the first screening or sensitive marker, basically in your iron studies, there's an iron overload picture, as one would expect. So an increased iron, and as we saw from the different causes that can affect iron interpretation, but the screening would be that of an increased transferrin saturation, bearing, as we spoke about how women through menstruation and such factors, that they have a higher transferrin saturation as a cut point for us to think of hemochromatosis or an iron overload picture. And then with ferritin, that is quite raised, higher levels in men, and also greater than 200 for women, which is a lower cutoff. But of note is that on the iron studies, you would see obviously that iron overload picture, and you would try and do differentially go through the different causes. And then once you've excluded that, or you have an increased suspicion based on perhaps family history or something like that, then one would consider your genetic screening. Your FBC, all those causes we spoke about in terms of anemias, iron loading anemias, for example, that we would be able to, anemia of chronic disease, or chronic diseases that you would also be able to pick up. Liver functions, although most of them would be minimally transaminases, for example, wouldn't be that much elevated. So, but it is something that you would look into. And also when we look at the complications of hemochromatosis, obviously one would like to do a fasting blood glucose and HbA1c just to check for diabetes. Imaging, in terms of MRIs or liver biopsy, but we'll explain why liver biopsy, especially in patients that have serum ferritin levels that are greater than 1,000, that would be something to consider. But genetics gives us the ability to be able to pick up patients that are non-symptomatic and really to avoid this invasive, although it is the gold standard, but there are ways to just identify these patients without doing that. Additional testing, your echo for your cardiomyopathies that you may see, hormone levels, especially when one is looking at investigating hypogonadism or various causes. So this is just to go into more why I was highlighting the genetics. So with the DNA testing that we do, it gives us that a chance at a definitive diagnosis in patients who are susceptible or at risk, or patients who have suggested biochemistry without the need of a liver biopsy. So what the kit we use at PathCare is the HFEV2 kit with this diagnostic assay that gives you a qualitative identification of the three most common variants of the HFE gene. So there are rare polymorphisms that may present. We saw the very rare or less much rare mutations that may be missed because they're not included in the panel. But I just also wanted to mention the financial setback for this. So currently it is about 2,400 or 2,500 cash upfront, but most medical aids that do pay for it, or if there is a discount, may be ranging between 1,900. So it is relatively, depending where you are at, in terms of your access to this financial resources, this may be a good tool that one could use. And those rare mutations that we spoke about that are not tested routinely because of how rare they are, there is an opportunity in patients that are that you are thinking of the other, especially, for example, in your younger patients where you are thinking of that juvenile hemochromatosis. So there is a panel that is offered in the USA, and this panel is about 8,500, depending on the exchange rate that we have. But this panel will whether you request a single gene or the full panel, it will test for all those genes that all those mutations that we spoke about, and obviously. This is also financially not billed through medical aid, so patients would have to pay upfront, and they, if positive, at-risk family members can be tested free of charge within a certain number of days. But the turnaround time is about 3 weeks, so that is just something to consider if in a patient that you really suspect that there could be other mutations that are present. So complications, as we spoke about the deposition of this iron, which causes oxidative stress on various organs. So hepatic iron overload that may present with fibrosis, cirrhosis, and most importantly, what we are concerned about is your hepatocellular cancer, where there is increased risk of progressing to this in patients that have this. Diabetes, we spoke about, so iron deposition in your pancreatic beta cells, the sparing of your alpha cells, and that discoloration or that bronze skin that comes from hyperpigmentation due to excessive melanin deposition stimulated by your excess iron. The effect of this on pituitary iron deposition resulting in various hormones being affected, patients having hypogonadism or hypothyroidism, and this makes it important to consider this when investigating patients with amenorrheas or hypogonadism. And then cardiac overload, iron overload. So these patients presenting with dilated cardiomyopathies or arrhythmias, central nervous system as well. There's an association of generalized cognitive impairment with these, with neurological abnormalities, and erythropathies where there is osteoporosis or there is this calcium pyrophosphate, calcium crystal deposition in your joints, and this results in patients complaining of arthritis and similar problems. And then there's susceptibility to infections, as we spoke about the interplay between that and your certificates. I think this we already covered. I just wanted to also touch on your porphyria. So PCT results from a deficient level of uroporphyrin decarboxylase. This results in increased uroporphyrin excretion in the urine. And these patients generally will have skin lesions, so presenting with vesicles or ulcers or hyperpigmentation due to excess porphyrins that result in your photosensitivity. But the issue of having iron overload, a key feature of the hemochromatosis, is that this is a significant factor in the diagnosis, development and progression of it. So elevated iron levels can inhibit the activity of this enzyme that is already deficient, and this will exacerbate the condition. And these patients would respond to venous lixiviation. Transfusional iron overload. This occurs a lot in patients because of various conditions that result in intractable anemias. These patients are exposed to quite a lot of transfusions, and this cumulatively, as there is no pathway exactly for excretion of this excess iron, and it's an accumulation effect of this. And the iron deposition is in your reticular endothelial cells, and these patients would respond to chelation therapy. So in terms of cancer risk, iron is potentially carcinogenic via several mechanisms, including the fact that it is immunosuppressive. It has immunosuppressive properties, and it plays a role as an essential cofactor for tumor cell growth and in catalyzing the formation of hydroxyl radicals. So what we are concerned about, especially, is the increased risk of hepatocellular cancers and other cancers as well. Of note, rates of cancers are much higher in patients with cirrhosis, and rates of liver cancers are also higher in males, especially those with your common mutation, your C282Y homozygotes. And then with regards to treatment options, the major treatments for iron overload include your venesection or therapeutic phlebotomy with, for those that are without significant anemia, and those patients with anemia or heart failure, and where chelation can rather be considered. So also there's also the point of your dietary considerations in terms of these patients. For example, the use of vitamin C with red meat, or restricting red meat and alcohol intake, as we saw the effect of it on hepcidin, and encouraging fibrates and antioxidants, most importantly, and also the education of avoiding iron tablets or other forms of food supplements that contain high levels of iron. But with the iron chelation, this is expensive, but can be considered in certain patients. For example, if the patient is already anemic and phlebotomy is contraindicated, then the use of these chelation therapies can be instituted. So the prognosis, we see that it is a treatable disease if you are able to suspect it and diagnose it, or and really institute therapeutic measures to prevent complications. So it is treatable and preventable, and our access to genetic testing gives an overall improved prognosis for patients that are preclinical or where they have a high risk populations or in families. And this also allows for screening for other family members. And then also just to say that with patients that have fibrosis or cirrhosis, that is a main prognostic indicator at the time of diagnosis. And liver transplantation for hemochromatosis is associated with a poorer outcome. So picking up these patients early and preventing the complications is really beneficial overall. So in conclusion, hemochromatosis is common yet under-recognized cause of iron overload. Screening measures of your iron studies with obviously the correlation with clinical findings and clinical judgment in terms of when, especially in the patients that we see where there are a lot of patients that are in hospital in inflammatory processes, that it may be difficult to screen, but something to think about, where to emphasize that the ability of or the availability rather of HFE genotyping that could aid diagnosis in patients that we clinically suspect. Thank you so much for your time, and this is the end of
Thank you, Karabo. This was quite comprehensive kind of dissections of hemochromatosis. It's quite in detailed form. And of course, I've learned quite a lot. I never really thought about the types of hemochromatosis. We always know really two, but I didn't think that was classified type 4. That tells you how much we have fallen behind during our learning time. Notice, I think you went quite a lot of details about it, and I think even the clinical presentations that you haven't gave anything out. And just another comment, I think perhaps next presentation will be really presenting about secondary causes of iron overload. And I think one of the things that you alluded to is the fact that our testing capability of disease in South Africa is limited. We could only test to a certain point, and then of course the fact that it's negative, that means probably just negative to us, but maybe to the rest of the world, there's a possibility that there's genes, other tests that had more higher power that can probably get us to the diagnosis, because we've seen quite a lot of them, and many of them have really been missed, and especially the link with the hepatocellular CA. And that's part for me is something that, and also liver cirrhosis, that probably one of the biggest things that, decrease people's lives, mortality, increase mortality and others. So I really want to say thank you. This was really quite good presentations. And I think for the students out there, I think this is for, you don't need a textbook. You just to follow the presentations and you can get your distinction. And then I think we also had a very interesting patient in maternity ward with Dr. Godinho. That's diagnosed with porphyria. And we were just yesterday thinking that we must do phlebectomy. But now you see I've linked them very quite nicely. I think the HB was about 15.5, yeah. But she's obviously a female young age, so means the iron might not be higher, but that does not exclude the fact that she might have hemochromatosis underlying. So maybe some that we could also check what is in there.
How high was the ferritin?
Ferritin, I think we did it. We're gonna check. But iron was 15.5, so we're waiting to see the ferritin. Yeah.
That's what I
Yeah, I think we'll just have a look at that. Yeah, because she just present with kind of acute abdomen. Yeah.
Because the concern is that it's a fine balance. When you say that you haven't seen a lot of young patients, it's not that common. But I've got a young girl, or I had a young girl who's about 15 or so, active, netball, work, very active in the team and everything, and just complained of fatigue. And she just couldn't breathe, she was very short of breath. And I mean, we knew there was a history of hemochromatosis. We tested her, she's positive, she comes in with iron overload, and it's a fine balance between, I'm not going to start her on a chelator because of all the side effects of the chelators. And she's young, and active. So we've been benisecting her as needed. But it's a fine balance between the HB, then, because she's having her menstruation. So I think the iron for actually almost 6 to 7 months, I hadn't venisected her because I think the menstruation was compensating for that, but she was, that was the kind of symptoms that she had. So it is a fine balance between deciding on venisection, especially in the maternity ward, those kind of things are a bit tricky. Then with the treatment of it, we use Desferazerox, which is Exjade, and Jadenu, which is available as chelators. But the problem with that is the side effect profile is quite toxic. There's ototoxicity, there's visual toxicity, liver, renal, cytopenias, diarrhea, those kind of things are all there. So you kind of have to inform the patient when you start them that actually these have a lot of side effects, and you really have to weigh the pros and the cons before you initiate chelation agents. But venisection is the easiest one. If they tolerate it, you just do it regularly, depending on what the iron profile is, even if you monitor them every 2 weeks or once monthly, until the levels become safe. Because beyond the 500 is where the toxicity, 500 ferritin to 1000 is where actually the toxicity starts.
The other complication with this is the cardiac impact and the liver impact. You will not see it on a regular echocardiogram or an ultrasound. You actually have to have a specific T2 star MRI to be done that measures the overload capacity or what has been overloaded. And the only thing that really would help perhaps reverse that would be XJ, not the desferoxamine that you talked about, but the desferazerox would help to reverse those effects more than just removing the iron that's there currently. So it's quite a complicated.
Can I ask something? I have two questions. One is if we are managing a patient now with hereditary hemochromatosis, as a chronic patient, we're doing venous sections on a regular basis. What is the ferritin that we are aiming for?
Less
Is
than
it to keep
500.
it below 500? Yeah. And then
If you can get it normal, I always target it to as low as possible with normal HB. So even if it goes down lower,
as long
it's
as you're
okay.
monitoring your
And they're
HB.
not symptomatic for an iron deficiency.
Yeah,
Yeah,
not
so
gonna be
that's
good.
where I would.
And then the chelating agents are they quite expensive or?
I think they are, but we do get it from the medical aid. It's not
Because
been an issue.
at one stage, I had a patient who said that she was referred to me because she was undergoing venesection, but she was saying her vascular access or to get a
yes.
vein to actually venesect enough blood was becoming a real issue. And yeah, in those cases,
Yeah.
that when you would
No, I would
Consider
actually
it or-
consider putting something like a PIC line or something like that. Because
Okay.
I mean, it depends on the comorbidities. If she's got no other comorbidities, she's happy with the risks that you've explained for the chelators and she's willing to go on it, you may not have to continue with it for the rest of her life. You see, you just have to bring it to a safe therapeutic level or not therapeutic, but a safe level of ferritin. That's your target.
yes.
So if you need just a brief period of chelation, then you just keep monitoring her. And then when it peaks up again, then you reintroduce it. That's also possible.
So it does not. I mean, basically, it's not going to be necessarily continuous treatment the whole time
No.
with it.
That's why I try to hit at the lower target of ferritin levels.
Okay.
Then just
monitor.
monitor her regularly. And when it starts again, you just venisect it. So once you kind of get into a flow, because I've had a patient who I've had to venisect every 2 weeks just because of the toleration to the procedure. Every 2 weeks for about 2 months, then she sort of normalized. Then I do it once a month. You can just stagger it out like that. And there's actually the blood bank can do that for you, the venesection itself. You just have to put it there for.
Yeah.
So and they will restrict. They will only do 4 venisections, and then you have to see her and then check what the levels are, and you see how quickly she increments. And I think that will give you kind of like a balance.
So, an interesting thing that you said that it's mostly, I don't know if it's the genetics, it's the Caucasian males that have a more genetic predisposition. I remember when I was a student, you were looking at black males because of that was, I don't know if it's in old days where they used to make a beer in the alcohol with increased absorption of iron.
Yeah.
So
I did read about it. That there is also a contribution of some where there's ferroportin mutations in combination with that consumption. So there's a predisposition. But
Even if they are heterozygous, they may not have any symptoms unless there's something that additionally, it's like alcohol use or those kind of things. But I don't know how often that practice is anymore. I think it's from the iron vessel. I think that was an old one.
More like a clay now. But
I think maybe in the rest of the African continent, I think it's quite appropriate in the context of African continent, where still the life still like in third world countries where probably they use those pots for making food, beers and everything. So I think probably it's very appropriate there, but obviously it's something that obviously you have to think about it. As I say, always there's no substitute for thinking. So you kind of have to look at it, and perhaps on our context as Africans, of course, we need to start looking at the link that maybe, maybe could have been heterozygous people that actually, because not everybody who have actually drink those beer had present iron overload. So probably have to be some kind of link. So means we always the questions, what make them special that actually develop secondary or iron overload. So I think maybe some that we could think about, because I think the test is not available. The capacity to actually detect those, even normal iron, you cannot do it most like Malawi. It's difficult. I don't know whether it's there now, but I think it's difficult. Even Mozambique, which is neighbor to South Africa, again, it's very challenging just to do a simple kind of investigation. So yeah, I think.
I've got another multi-level question. I don't know if it can.
But any question online? Dr. Okoli?
Yeah, good morning. No question from my side. Great presentation.
Thank you. Thanks for joining us, Doc. Okay, in this case, let's close this one and move to Dr.
Bye-bye.
Thank you.